Hi, everyone. Welcome to episode 2 of the Rehab Revolution with our host, Dr. Gariffo. I'm happy to have you here today and kind of go through all of the things that the Rehab Revolution redefines. I know this is the second episode for Rehab Revolution, really focusing on where rehab meets revolution, bridging the body and mind, redefining recovery by bridging the connection between physical therapy and mental clarity. Each one of these episodes of the series of 12 will kind of go through groundbreaking approaches like hyperbaric oxygen therapy, dry needling, and telehealth, which I know you did talk about a bit on episode 1, so happy to get in a little deeper today. And then also going back to telehealth, while also sharing some of your transformative patient stories and experiences and debunking some rehab myths and really going through how healing becomes revolutionary. And the specific episode 2, we will focus a little bit on physical healing meets mental strength and understanding more about how physiological challenges of recovery, and how addressing mental resilience can accelerate physical rehabilitation. So gonna just jump right in here with you and kind of start asking you some questions.
Yeah, let's do it.
Yes. So Dr. Gariffo, on the last episode, I know that there was some talk about your journey into rehabilitation, but I wanted to go a little bit deeper today and really understand or find out a bit more from you about if there was ever a specific moment in your own life that you personally experienced the power of physical therapy yourself.
Absolutely. Great question. I guess I want to start with when I was injured as a ice hockey player. So I learned physical therapy 2 ways. One was not so good an experience. The other was a great experience. So the first was an injury where I was injured playing ice hockey and I injured my shoulder. And I went to see a physical therapist. I loved the hands-on approach. I loved the camaraderie. And I loved how we were able to build a relationship, even around the shoulder and what I was doing that weekend, or was I playing still hockey? And you see the physical therapist 3 times a week, where you see your doctor, your surgeon, or your neurologist maybe once every 3 months. So I really developed a relationship with my physical therapist. I knew then that I wanted to become a physical therapist. However, Layla, my first job, I experienced everything that I didn't want to do or be as a physical therapist. And I learned a lot from that experience. So I lasted there for 2 years. And what I uncovered from that first job is that I wanted to do the exact opposite of what that physical therapist did with his patients. Let me just give you an example. My paradigm shift was my first job, where I learned, okay, how do I treat my patients better than he's treating his patients? And that's really simple. It comes down to alliteration of the 3 E's when I work with my patients. And the first E is evaluation. Is your evaluation comprehensive and personalized? And every one of my evaluations is comprehensive and personalized. Whereas when I experienced that first job, you would see the physical therapist day 1 and day 30. So day 1 was your evaluation and day 30 was your reevaluation. In between those days, you were treated by an aide, an unskilled, unlicensed aide. And I have no aides in my practice. So the first one, most importantly, is the evaluation appropriate and is it comprehensive? The second E is evidence-based practice. My practice is not haphazard. It's not based on conjecture, or it's based on literature. It's based on research, and it's based on experience. 30 years as a physical therapist this June. I'll celebrating 30 years in practice. So I learned a lot in 30 years, and I know that everything that I do to my patients and with my patients is evidence-based. And the last E, I think is the most important E, is engaged and empowered patients. My patients are educated on their diagnosis, they're educated on the rehab process, so they're engaged in their own rehab. And they kind of have the self-interest to do their own work, hard work, in the gym as well as at home for their home exercise program. Also, collaboration in decision-making. Okay, you're in a lot of pain. I think we should pull back for the next couple of days. And instead of coming in and seeing you on Wednesday, let's push to Friday. So that's what happens when you have empowered patients. They're able to communicate with you and not be intimidated by the communication. The first thing I do with every single patient every morning is I go in the room and I say, okay, how's it going? How's your shoulder doing? How was your weekend? What did you do? Did you play tennis? Did you go on the wedding? I know exactly what they were supposed to be doing that weekend. And they really receive that well because they're empowered, and they're empowered for their own recovery journey.
That's amazing. And also 30 years is very impressive. So congratulations on that. I'm sure you have learned a lot and a lot of trial and error, I'm sure. You mentioned your first job. Was that your first job specifically as a physical therapist, or what was the actual job? It was.
Yes, as a physical therapist. So I went in on fully blinded with the experience of I wanted to go set the world on fire. And I landed in this practice and it was not a good practice, but I stuck it out because I still was interacting with patients. I was still cutting my teeth with treating patients, but I knew my approach was going to be the polar opposite of his approach. And that's a paradigm shift. It really is. You learn a lot when you can just flip it 180 and do the exact opposite and succeed.
Absolutely. I definitely agree that sometimes having an example of what you don't want can really, really make you realize what you do want, especially in healthcare. Absolutely. And then the 3 E's you mentioned, was that something that was your own approach? Is that something you created, or is that it is?
It is. Yes, absolutely. The evaluation has to be spot on. You have to engage your patients. You have to empower your patients. You have to offer research-driven interventions that are evidence-based, because it can't, like if the patient ever comes to me and says, why are you doing this exercise? And every one of my staff members know, my aides know why I'm doing what I'm doing. My patients know why I'm doing what I'm doing. I don't just stretch your shoulder out. I say, Layla, the reason why I'm flexing your shoulder is because you have adhesions. And this is why we're doing this. So okay, this makes sense. Versus you just, I guess he's fixing me. He's just stretching my shoulder. And then when you empower your patients and you educate your patients, they're much more involved in their own treatment because you have their best interest at heart. And that really is crucial. The education is really crucial to rehab process.
Absolutely. I definitely think that empowering and educating patients will definitely make them feel empowered on their own as well. So definitely, I think that's a wonderful approach that you have for your patients. And then I know oftentimes in physical therapy, I've heard the term like pushing through the pain is common in physical recovery. But what role do you think that mental resilience can also play in rehabilitation?
That's a fantastic question, because what I see is with the patients that are resilient, mentally resilient, they adapt to setbacks. They really manage stress better. They maintain a positive outlook by being resilient. And by being resilient, also have a really strong carryover for pain control, because I then know this is why I'm doing this. And there's a big difference between, good pain and bad pain, but mentally resilient patients can manage through the pain process and enhance their motivation as well as their engagement, because they're able to better cope with setbacks. I mean, that's really important, having that resilience. So you see it in many patients. You could see it in a 16-year-old, you can see it in an 86-year-old, but you know it when you see it. You know how successful a patient will be with their rehab in the first hour of the evaluation. I know it as soon as I see them, as soon as I evaluate them, and I know if they're bought into the process, they're the resilient patients. They're the ones that will succeed in the rehab process.
Is there something that you would say with those patients that you can identify as resilient in them within that first hour? Is there a common trait that you think they share? Or is it just kind of a gut intuition that you have with your experience?
I guess 30 years of experience, I see it's a gut check, definitely. But most often the patients have that dogged pursuit for their own best outcome, right? I come into it and I'm an elite athlete, and I've dealt with many elite athletes, or I'm an 86-year-old with a total hip replacement, and I want to go on my walks with my husband again. I'll know it based on the evaluation. It's not the evaluation, not the outcome of increased strength or increased range of motion or better balance. The outcome of, I want to hold my grandkids in the air again. I want to play golf again. that's who are mentally resilient because they have their outcomes already lined up and they know where they want to go and how together we're going to get there.
Absolutely. Their purpose, essentially. They have that driving force within them. And then talking about the rehab process, is there something that you found or you find surprising about the rehab process that doctors don't always particularly talk about?
Yes, there's this, recovery is nonlinear. I mentioned setbacks. I mentioned there's the value of setbacks because we have ebbs and flows, we have plateaus, we have temporary setbacks, and they're unpredictable. And in those periods of rapid improvement, oftentimes the patient will say, wow, this is really working well and it worked quickly, but the same exact patient, the same ACL patient a week later may not recover as quickly, or they may not be in as good shape as the prior patient. So the value of setbacks, most often docs miss that, as well as I call it the strategic use of controlled discomfort, having that therapeutic pain threshold and discussing that and communicating that with the patient, knowing what is good pain, what is bad pain, educating the patient and over-educating the patient every single time you see that. Most of the times when I talk to my patients, I already know what their abduction is. I already know what their shoulder range of motion is and their strength and their pain levels. I want to know, how are we doing? Like, are you able to do more during the weekend when you're not with me? Are you able to do more with your wife or your husband or your kids when you're not with me? Are you back on the bike? Are you back golfing? That's most important to me. I want to make sure that we're on the same page as to what your outcome is. What is your purpose? Like you said, what is your purpose for rehab? And that's well defined upon the evaluation. I go back to that and I reference that, 6 visits in, 10 visits in and say, Layla, when I saw you 2 weeks ago, our goal was to have you golfing again 3 weeks from now. How's it going? Oh, I'm absolutely back to golf and I feel fantastic. You work wonders. And I see that a lot. I'm not being pretentious, but I do see that a lot because, again, this constant communication with me, not my aide, not my front desk, not my secretary, it's with me one-on-one the entire treatment.
Absolutely. And I'm sure that encouraging them and educating them and empowering them also definitely ties into them doing the work themselves on the weekend as well.
That's right.
Are there any physical conditions where you think mental health plays a bigger role than people may realize?
Yeah, again, I think of a couple diagnoses that I deal with a lot. And the first one is chronic pain. And the chronic pain patient has that instilled, embedded, if you will, depression and anxiety because of trauma. They've been dealing with pain for years and years and years. They've seen every specialist there is. They've seen the neurosurgeon and the surgeon. They had injections and they're on this medicine. And they come to see me and it's like, what can you do? What has not been done to me to date? Oftentimes that results in either dry needling or Graston or hyperbaric oxygen therapy, really unique differentiators that I provide that not many other physical therapists provide. There's nobody in my area that provides what I provide. And that's my kind of like coup de grace, if you will. My brand awareness is based on my experience, my knowledge, and my expertise. I'm the second, diagnosis specific patient that really has that mental health, physical health, kind of like 1-2 punch dilemma is the cardiovascular patients, the patients that have CHF or they have heart disease or they have just labored breathing. They're at their wits' end. They've been dealing with cardiovascular issues for, again, like a chronic pain patient, 20, 30 years, 15 years. And they come in and oftentimes there's that cross referral between me and my psychologist where we can co-treat. So we can treat Layla's depression and anxiety in the same clinic, and I can treat her chronic low back pain or her chronic neck pain or her CHF status and her breathing training around those specific diagnoses. There are multiple diagnoses, but those two kind of like rise above all the others.
Yeah, I can see how they definitely go hand in hand and definitely help balance that out for the patient. What would you say is the biggest myth about rehab and it drives you crazy? And
I gotta smile, Layla, because I've been on this soapbox, I think, for the last 15 years. And what drives me absolutely crazy is that physical therapy is not a generic thing that people get, right? Because if that were the case, you can get it from anybody. You can get it from your primary care doctor. God forbid you get it from your chiropractor. You can get it from your hairdresser. If physical therapy was merely a service that you simply get, that drives me crazy, because what happens is at that point, physical therapy becomes a commodity, because a commodity is I can get that there, or there. There's no differentiators. So how I differentiate that is my patients come to see Dr. Gariffo not to physical therapy. They come to the profession of physical therapy. They don't go get a service of physical therapy. I know it's semantics, but it means a lot. It means a whole lot, because our brand, my brand, is what I do to my patients. It's not this faceless, generic, big box treatment plan that every other physical therapist can do. And because the doctor says, okay, go to physical therapy, you're like, okay, let me just pick a spot on the mat and I'll go into physical therapy. And physical therapy is physical therapy is physical therapy. So that's my kind of soapbox that drives me absolutely crazy, is that other physical therapists that are friends of mine are okay with being a commodity. I am not a commodity.
Absolutely. And then do you think, definitely, I think not all physical therapy is created equal, for sure.
Right.
Do you think that myth itself is harmful?
Absolutely, yes, I do. Because like I said, there's a lot of territorial grabs on behalf of athletic trainers, massage therapists, chiropractors, primary care doctors, offering quote unquote physical therapy, meaning physical therapy is a service that I can offer as a massage therapist, as an athletic trainer. No, you cannot. It's a profession that I went to school for a long time to become a physical therapist. So I think that if we continue down this path of being okay with being a commodity, there's definitely going to be market share. Definitely going to be market share taken from us.
Absolutely.
Not from me, not from my practice. I can tell you that as a matter of fact, but from other physical therapists, yes. Because I do that now. I am not a commodity, but I'm definitely more willing to take patients from another commodity down the street that's a physical therapist.
Absolutely.
They go experience that. They come experience what I offer, and they're like, why did I ever even spend 6 weeks down there? Sign me up. I'm ready to go.
Sounds like your practice definitely speaks for itself pretty quickly. And I know with physical therapy, some people tend to believe, quote unquote, if it hurts, it must be working. And others stop therapy too soon because they may not see results. What's your take on both ends of the spectrum?
If it hurts, it must be working. There's a fine line, and that therein lies the skill set of a good pain, bad pain. I mentioned that a couple times in the past 20 minutes. So I'll just give you an example. Like, I'm working with a shoulder patient and I'm stretching them out, right? Or they're saying, I did my exercise this weekend and my pain is 6 out of 10. Okay, that doesn't mean anything. Is it a dull, achy pain? Is it a toothache pain? That's good. That's a good pain. Is it a sharp, stabbing, breathtaking pain? Bad pain. So therein lies the crux of having the knowledge and expertise and the skill set to differentiate good pain versus bad pain. And I do it every single day for every single joint in the body for all my patients. So I know that, okay, I am going to push you. A total knee replacement is a fantastic example. Oftentimes, a total knee replacement will freeze in flexion, meaning they don't get the amount of mobility they need to bend their knee. So I have to literally crank on their knee through tears. Oftentimes, they're crying, saying, stop doing that to my knee. I know they need 100 degrees to be functional. If they're stuck at 85 degrees, that's a problem. And that's a long-standing problem with whenever they leave me. So oftentimes, I'll be on the phone with the surgeon and say, Doc, look, your patient's stuck at 80. I'm going to crank it on this knee. They're going to be really inflamed tomorrow when they see you. But if I don't do that, Layla's not going to get her flexion back. And I educate the patients around that. And oftentimes, I have them bite a bullet. No, I'm just kidding, Layla. Not bite a bullet. I just have them, don't scream out loud. Just don't scream out loud. If you scream out loud, I got to put you in a private room. So there's the good pain, bad pain. And then also, too, having the skill set to understand what is overexertion. What does that look like? What does that mean? That therein lies the thing, like, it must be good because I'm Like, I'm winded. What's your RPE? What's your rate of perceived exertion? What is your number? How are you feeling right now? Can you talk to me right now? You're on the treadmill. It looks like your breathing is really labored. Therein lies that kind of like expertise skill set to understand, like, this is fine. You're okay. Let me take your blood pressure, but we're going to keep on doing what we're doing. We're not going to stop. There's the kind of like more is better. And then also the patient that comes in and says, wow, it's a slow process. I'm really not getting any better. Understanding, educating the patient on it is a slow process. This is surgery, or this is a strain or a sprain. The differentiation between the diagnosis of a fracture versus a post-op fracture versus a strain or a sprain, therein lies my education upon my evaluation. So you know exactly what's expected. I'm not going to go into an ACL patient and say, you'll be good in 3 weeks. It's never going to happen. 6 to 8 weeks is a normal length of stay for that patient. So I have to educate them on the gradual nature of recovery. And that all happens upon the evaluation. So you know exactly what's going to happen over the next 3 to 4 weeks.
Absolutely. I think helping patients manage the expectations and having realistic timelines must alleviate some of their stress for sure. And I'm sure you know good and bad pain difference, how to differentiate that, but patients might just think it's all bad pain. So lucky they have an expert to really know the difference between good and bad pain.
You know, it's funny, Layla. So I don't tell my patients this anymore, but back in the day, PT used to stand for pain and torture. Not sure if you're aware of that, but
I have not heard that one, but I can understand why.
Yeah.
That's funny. Going a little bit deeper into the specifics of your practice. Within your practice, I know you've been doing some innovative techniques, such like hyperbaric, oxygen therapy, dry needling, and telerehab. I'd like you to go into a little bit about each of those if you can. And then also, what's one breakthrough treatment that's just blown you away in terms of the results?
Yeah, that's great. So let me start with hyperbaric oxygen therapy. So really just the net on that. What that is just, if you think about it, it's pressurized oxygen in a controlled environment. So you're in a chamber and it's 100% oxygen. You have a cannula in. And then what that does is at the cellular level, it leads to rapid recovery. It's the reason why Justin Bieber sleeps in one every night. It's the reason why all the elite athletes, all the football players that I treated sleep in one every night, because of the rapid recovery. Vocal cords, shoulder pain, knee pain, hip pain, doesn't matter where the pain is. Hyperbarics is all about rapid recovery. So the analogy I like to say to my patients is the absence of oxygen is the presence of disease, meaning if I have a sprain or a strain or surgery or a wound, if that's not oxygenated, I'm not going to recover as fast as I would if it were oxygenated. So there is the kind of the story around hyperbarics. Dry needling is more of a twofold. So upon palpation, you may find a knot, like a patient knows what a knot means, like a knot in your neck or your trapezius or your back or your knees, your quads. So I go in and I find that knot. So that knot might be 3 inches deep. I can't get to it were it not for a needle. So I might put a needle in you that long, penetrate that muscle, and then the muscle fibers that were like this because they're in a knot, then deflate and become like that. And I feel it under my fingers. So it's the rapid recovery upon palpation and penetration of the needle. And the last part of that would be the telehealth model. What the telehealth model has done for us with psychology as well as physical therapy is allow me to treat a patient. Let's say Layla can't come in today because she's a cold or she's sick or she has to take care of her daughter. So I could do a telehealth visit with you and your daughter's right there next to you because she's sick in bed, and we could do your rehab right there. It's been gangbusters for us, as well as psychology. So let's say our psychologist can't make it in to the office 5 days a week. She can only make it in 3 days a week. We could set up a telehealth visit where Layla's in the clinic and we have a full monitor, full telehealth clinic set up in the office. And then you sit there and you have a private conversation with your psychologist in our clinic, and she's home. So it's kind of vice versa of what you were with physical therapy. And there's so many stories and anecdotes around like the wow factor around those modalities. But I think the most important one for me is hyperbaric as well as dry needling. So this one patient, I had 3 years of chronic occipital headache. So occipital is the back of your head. Oftentimes the muscles below your neck, called the suboccipital muscles, are in spasm. They squeeze a nerve that supplies the back of your head and you have headaches. So I treated her, palpated suboccipital muscles, had a headache, dry needled her. 5 minutes later, no headaches. Hasn't had a headache since. She had a headache for 2 years. 2 years. 5 minutes. So needless to say, she's my biggest cheerleader. She sent everybody to me for dry needling, for physical therapy, for hyperbarics. But there's many, many stories of patients. It's a bad business model because I heal the patient immediately versus treating it for 8-10 visits. But I'll take it for what it is. So and then hyperbaric oxygen therapy. I had a patient who came in post-COVID. Post-COVID symptoms are pretty severe, and those patients try everything, and they'll pay anything to just not have these symptoms. So I had her in the hyperbaric chamber for 4 visits, and she came out symptom-free. She had post-COVID symptoms for 3 years, and she came out 4 treatments later, no more symptoms. And then what that does is that really just drives the cycle of referrals, because the best referral is a patient referral. And that's where I base my business on. All my patients referring other patients. It's not about like going out and trying to take out this doc or this person to dinner and have drinks. That's not how I develop my business. My business is through treating you like royalty, because then you'll go back and tell your sister and your mother and your brother who I am and what I do. And that's how I base my my practice awareness and my brand awareness on just my skill set and my experience.
Absolutely. I think a word of mouth referral in most businesses, especially in healthcare, definitely goes so far. Sounds like you definitely gave her a new lease on life. 2 years with a headache does sound pretty miserable, so I'm sure she thanks you every single day. And going back to kind of talking about telerehab and how telehealth has actually really just changed the health and medical world so drastically, especially in the last few years. What role do you think technology plays in the future of rehab? And do you happen to see a day where AI or virtual reality could be a part of therapy, or your therapy specifically?
Yes, absolutely. I feel that it's a profession. It's a great profession because it's not one of those professions where AI will replace physical therapy, because physical therapy by nature, by design, by definition is physical. If I'm not touching you, and I tell all my new grads this, I kind of, on a side note here, that I've been in physical therapy before. I've been in clinics before where I worked, and I saw a patient interact with a physical therapist that never, ever touched that patient. And I'm like, that's not physical therapy. So every patient I see and I touch, I palpate, or I diagnose, or I stretch out. So AI will never replace that. The empathy, the mindfulness, the touch, the physical touch of a human. However, it can definitely complement and supplement my practice in that there's wearable items, there's virtual reality systems where they're having great gains with stroke patients and with post-op patients and Parkinson's patients, where you can have the goggles on and you can kind of walk them down a path for gait. A lot of balance work has been done around AI with, again, with VR and with wearable items. So I could put like pants on that have electrodes on there, and AI can diagnose that gait, or say that there's a balance deficit based on the green screen behind the AI or behind the cameras. And I've done a lot of that research in the past 15 years. So I guess the long answer is that AI will absolutely complement and supplement physical therapy, but it will never replace physical therapy.
Absolutely. I think also it will never really, there's no interaction quite like a human interaction.
Yes.
So especially talking about empathy, for sure. And for those listening, or for anyone you may know who may be struggling with rehab, either physically or mentally, what's one piece of advice that you would give them?
How about 3 pieces? Can I give you 3 pieces?
Go right ahead. You give me as many as you'd like to.
Yeah, I guess the first would be just be patient. Just be patient and be kind to yourself. Just be, appreciate the journey, you know, just really focus on the journey, not on the destination. We know based on the evaluation what that destination is, what that outcome is, but let's really enjoy the journey. We're going to be together for 10 visits, 12 visits, 15 visits. So my piece of advice to the patient is be kind to yourself, enjoy the journey, and celebrate those small victories. I guess that's the third point. You know, you come in and your pain level was an 8 last week, and now it's a 4. That's a big, big deficit. Let's celebrate that. Let's talk about that. And I'm really proud of the celebration around the small victory. So in my clinic, it might sound a little corny, but it really works. So hear me out. So in my clinic, every single discharge is celebrated. Meaning, if I'm with a patient in the room and I have 20 patients in my gym, my aides know to come get me and say, Layla is being discharged today. And I say, all right, guys, everybody, quiet down. Layla is being discharged today. And I embarrass Layla. I say, Layla, okay, give us a little story. Where were you 6 weeks ago? I came in, I saw Dr. Gariffo, I couldn't move my arm. Now look at my arm. My arm's great. I feel great. I'm playing tennis again. And we all clap. I give you a nice big clap. I give you a t-shirt. You put the t-shirt on. And that's how we celebrate our patients. You got to celebrate the victories. You have to celebrate the victories.
No, that's super exciting. How do you think that the patients take to that? Do they tend to like that?
Oh, they love it. I always preface it with, if I see this introverted patient, I know like I'm not going to pull her out in the front of 20 patients. I already planned that out. So I have her in the back room and I say, here's a t-shirt. Congratulations. And you know what also too is that oftentimes we may discharge a physical therapy patient, but you're still there for psychology or vice versa. So we have those shared patients that are still coming in for psychology, but may have been discharged from physical therapy. And we have a lot of patients in this area that have this awesome logo on the back of their shirt, the rehab room.
That's awesome. Are you ever just out sometimes in Philly and run into some of your patients, or
all the time? All the time. I wear my gear everywhere. My wife yells at me all the time. She says I wear it way too much. But even in church, like I'll leave church and they'll come out and they'll say, hey, is that your practice? Yes, it is. Oh, but my shoulder's killing me. Can you take a look at my shoulder? I said, no, I can't. But you can give me a call and I can schedule stuff.
Absolutely.
Yeah. So it's great.
No, I don't think you could wear it enough. That's your brand. You should be proud of it and wear it wherever you go. Yeah. I know you're from South Philly. Is that where your practice is based as well?
So it's 30 minutes from South Philadelphia. I'm in Media in Delaware County, which is about 30 minutes from where I grew up. All my schooling was in Philadelphia. I was the Philadelphia Eagles physical therapist back when I first graduated, when I was still in PT school. So yeah, I'm a Philly boy, born and raised. Big celebration coming up this Friday for the parade around that huge blowout of the Chiefs, which I was so excited about.
That was definitely a blowout of a game for sure. Do you think you're going to make it to that parade on Friday?
I don't think so. You know, it's funny because my wife and I were still thinking about, like, they were supposed to have it tomorrow, but we're getting bad storms here tomorrow. So they moved it to Friday last week, knowing that we were going to get bad storms tomorrow. So if it was tomorrow, we were both going to go. But now that it's Friday, we have dinner plans. So we're just going to hang out and watch it on TV. There
you go. Yeah, Valentine's Day. Got to spend it with the wife, right? Happy wife, happy life.
That's right.
Absolutely. And I know, while we're on the topic of family, I know in the first episode you did mention having 3 sons. So are they, what are their age ranges?
Yeah, so so let's see. My proudest moment is I married my best friend 27 years ago. And she's a nurse and we have 3 beautiful, beautiful sons. My oldest son, Luca, he'll be 25 in 2 weeks. My middle son, Matteo, is 23, and my youngest, Marcello, just turned 20 last month.
Okay, so they're all pretty grown around that college, early adolescent, early adult age range. Do you think any of them want to get into the medical field or follow in your footsteps as a physical therapist at all?
My youngest son is in school now. He's a sophomore in college, and he wants to become a psychologist. He wants to take over the practice, but he wants to do it down the psychology path.
Okay,
who
that's
knows?
awesome.
Maybe I can convert him over to physical therapy, but we'll see.
Or maybe he could stay there. You guys can work hand in hand on some patients.
I'm not sure how that would work because I'm pretty stubborn with my patients.
I can see that. I understand why. And then I guess I just have another question for you before we kind of wrap up episode 2. When you think about the future of rehabilitation and healthcare, what particularly excites you the most?
We need to, I was just on a call last night with this neurosurgeon, and we were talking about this for like 30 minutes. We are not good advocates for our own best interest, meaning doctors typically don't fight the battle that needs to be fought for reimbursement, meaning reimbursement goes down 10% every year and our costs go up 10% every year. So you can't win if this is the direction you're heading every year. So cash-based practices like my practice is the future of medicine and definitely the future of physical therapy, because in my practice, I one-on-one see 2 patients an hour. When I worked for the big box conglomerates commodity of physical therapy 2 years ago, 5 years ago, 10 years ago, before I sold my practice to them, I was seeing 6 patients an hour, 8 patients an hour. You cannot survive seeing 4, 6 patients an hour. It's impossible because I can't give you the time that you deserve, that you're paying for. If you're there in the corner doing exercise with an aide, you're there with me one-on-one for 1 hour. That's how I want to run my practice. And this neurosurgeon, his 90% of his patients come from international because they're willing to pay the money to get treated because he only takes cash for his treatments. So people see the benefit of one-on-one care and they're willing to pay for that. People in pain want to be pain-free. Let me just tell you that. And they're willing to say, like, okay, I tried physical therapy, the commodity of physical therapy, it didn't work. And I went over to Dr. Gariffo and he just worked miracles on me because he focused on me and he educated me and he was there engaged with me every single treatment. That's how you succeed in healthcare.
Absolutely. Definitely. I think that one-on-one care goes so far, especially having that entire time and not being with aides or being in the whole system of, like you said earlier, how a lot of practices are run between front desk and all of those different variables, but just having that one-on-one time with you. And thinking about the future, let's say 5 to 10 years, what would be the best outcome for success for your practice with the rehab room?
Yeah, so we're already looking at number 2. So what happens in this world is that in the world of this space of physical therapies, the first one is usually the toughest. And I've done this before where I had 7 practices, sold them. My goal is to have 10 of these practices, cash-based practices that have the 4 pillars, physical therapy, psychology, hyperbaric oxygen therapy, and a full concussion clinic with diagnostics in all 10 of these facilities in the next 5 years. That's my goal.
Wow, that's definitely a great goal. I'm sure you will definitely accomplish it. And right now, currently, how many practices? Is it the one?
The first practice, yes.
First one.
Yep.
Okay.
We've been building this practice for 3 years. The model of care has been built for 3 years as to how do you treat a patient with psychology and physical therapy and also round it out with the hyperbarics and the concussion clinic. So it's been a slow build, but it's definitely more than worth it because the outcomes are just fantastic. And I wouldn't be surprised if other physical therapists or other psychologists try to do what I'm doing in the near future. But by that time, they'll be kissing my heels because I'll be well ahead of them. Right, Layla?
Absolutely. Sounds like the groundwork has definitely been laid out, just ready to hit the pavement and keep going and building. And I think that's about all the questions that I have for you today on episode 2. So is there anything else you would like to wrap up with or tell the listeners? Any last words?
Yes, two things. I guess if you go to physical therapy and you're not being touched, don't go to that physical therapist. Turn around, go somewhere else. If you're not seeing your physical therapist every single day, don't go back to that physical therapist. You should be seeing your physical therapist, not the aide, not the front desk, not the assistant. You should be seeing your physical therapist. And lastly, physical therapy is hands-on healthcare. That's what it is. So if you're not being stretched out or having manuals or doing something with your physical therapist, every single treatment, go somewhere else. Go to the rehab room, because I touch my patients every treatment.
Absolutely. And if for any of those listeners, they can just look you up and find you for the rehab room. And again, thank you so much for hosting this episode of Rehab Revolution and episode 2, where physical healing meets mental strength. Thank you again, and we'll see you next week for episode 3.
Awesome. Thanks so much, Layla. It was so nice to meet you.
Thank you so much, Dr. Gariffo.